Hello, everyone. It's 7 o'clock, so we're going to get started. Thank you, everyone, for joining us tonight. And before we do start, I did want to share with everyone how we can ask questions throughout tonight's event. What you can do is you can actually use the question function that you'll see on the control panel. It's just a little button that says questions, and you can submit there. We're also going to be checking NATF's email throughout the presentation, and that email is info@natfonline.org. So please feel free to send in your questions, and I will share them with Dr. Barkoudah after the presentation. And at this time, I'm excited to introduce Dr. Ebrahim Barkoudah. We're very excited to have you here tonight.
Thank you, Molly. Thank you. And thank you for tuning in and joining us for tonight's event. I do have a couple of slides that I would like to share with you. And I would like to use this platform, this session, to give you a couple of tips about what you would expect in the hospital during your hospitalizations. And the scope that I practice within, it's called hospital medicine. So I am on the medical floor when I am on the clinical service, taking care of patients, teaching, and doing my research. I live on the floors, as you probably put it, and I would like to make sure that I also address a couple of points throughout the presentation. My great interest is your questions and how we can keep this conversation going. A special topic for me and a topic of interest is about VTE, about preventing thrombosis. I'm not going to provide a magic bullet to prevent it. I would like to share with you how we could make it better and how we could reduce it, and how your hospital stay would be more meaningful and less hectic, because coming to the hospital is definitely a burden for you and your family. So the items that I would like to discuss, or the highlights for the next hour, is about hospital stay. What does it mean when you come to the hospital? Who should you talk to? I would like to make sure that you know who are the providers who are driving your care in your best interest, and how you'll be able to reach out and make sure what you see is what you communicate. And I would like to discuss the risk. And I'm going to use a couple of medical terms in my slides. I would like to explain it because it's that syntax, the medical lingo that we use during your hospitalizations, if any, and when you come advocate for your loved one, for your family, for your friends. We want to make sure we're all on the same page. And then how that would drive the discussion with the providers. Again, I live on the medical floors. I spend most of my awake time on the floors, and this is what I'm passionate about, and I'm passionate about providing the best care for my patients. And tips on staying healthy. We all like to have probably healthy food. I would like to give you a little bit more of specific tips about VTE prevention, and I hope the knowledge that we all learned today will spread and would help our patients and anybody who might be at risk for that. So let me just set the stage with a slide that I use in my presentations, my talk, is about the word hospitalist. What does it mean? Who are these clinicians that they will be caring for most of the adult, and now even the pediatrics patient throughout the US? So the field grew. It were a couple thousands of primary cares that they used to cross over the inpatient side, and that there was the beginning of hospital medicine. Now it is a field where physicians, they choose to go to. And beyond physicians, we do have physician assistants, nurse practitioners on the same front lines with us. And this slide just to show you that the field grew to about 50,000. Now we think there are about 60,000 hospital medicine providers throughout the about 5,000 hospitals in the U.S. And the goal is to focus on the management of complex care, of complex disease management. And the idea that we all know that if you work in the healthcare industry, or you know a friend or colleague or family member that works in a hospital, she or he will tell you that we are getting older, we are getting sicker, and we do have more tendency to carry diagnoses like diabetes, like hypertension, and so on. And we think that that risk portfolio will put us at risk to have the blood clot, the VTE. So,
Dr. Barkoudah, I'm so
yes,
sorry to interrupt. I just wanted to let you know that the screen is still showing your first slide.
I am so sorry.
No problem.
All right, the slide's advancing.
They're not at this moment. Let me make you the presenter again.
Okay, would you
I think
please?
maybe,
My
yeah.
apologies for this. All right, I hope that.
Here we go. So we can see your screen now.
All right, so let me just swap this, and my apologies. So I hope everyone will be able to see. This is the layout for our hour this evening, about your hospital stay, about the risk, about how you can improve that communication, the discussion, and tips on staying healthy. This is the slide that at least I start talking about for 5 minutes, and now you can all see. There are hospitalists, hospital medicine on the floor. They manage diseases. And I put down how many admissions, how many beds in the US. We have about 900,000 beds, and that's a lot. And I tell everyone, I tell my students, my trainees, my residents, that it's not the number, it's that number of one. Each patient is important. Each patient is a mother, is a father, is a grandparent, a son, a daughter that we care about, and we need to individualize the care to make sure we take care of each patient that we see. So let me just give you another topic just to see. This is the case that we always think about day in, day out. It's how we can always manage the risk and benefit. Every medication is a drug, and drug would have a benefit and risk. And the idea is how, in the context of having risk profile for having blood clot and during hospitalization, how we always making sure that is it good or is it not good to start medications. I don't want to drill down in the medications and what would be drug A and drug B. The goal here is for you to also get the other side, the clinician side and the physician side, and also the patient side. We are starting medications, and we always think about this. The benefit should outweigh the risk. We want to minimize the risk. We want to make sure that when you are in the hospital, you are not at risk or higher risk of developing any type of complications. Even with the small, teeny, tiny doses, they are still not physiologic. One of my quizzes for any students before they start their training, I ask them, what is the normal range for drug X? And I will give them a drug that's on the market, a blood clot drug or a seizure drug, and they focus on the therapeutic range. So they say it should be between 5 and 10. And the answer is wrong. The answer is 0. I do not have it in my system. And that's the idea that if you don't have it and we add it to anyone, we always need to be diligent. We think about everyone again, and N of one matters. This is not the way I usually discuss it with my colleagues in finance. This is not about if I get it right 80% of the time I'm successful. This is the science, the practice of getting it right always, 100%. My next slide is a slide that would summarize what we just talked about, the how you can balance that evidence and recommendation. We always need to assess, we need to think about it, we need to engage physicians, again, providers, most importantly, the patient in the center, and the most also important circle, the family that comes around it. And that's probably a good segue for also the support. The word support, it really supporting the patient in the center. And as you can see, it's complex. It's not just one-to-one relationship. We need to really understand the risk. We need to have clear recommendations. We need to also make sure that everybody adheres to guidelines for what would be the best for the patient. So when we try to provide support as to a friend or a loved one or a colleague, we also need to see it from the other side, where everyone tries to do their best, but that support makes it better, makes the healing better. And personally, I participate. I'm a member of the Schwartz Round committee. The Schwartz leadership committee is where we always try to bring these stories of one to discuss it with our bigger community about compassionate care, about support. Sometimes it's the medicine, sometimes it's the network that we built around our care. This is also a slide where I usually try to build that complex picture, but in the end of the day, it should be very clear and sounds in terms of methodology and how we can provide the best care. Each clinician should assess, customize, and then apply. And that is the art of how we can link the best science to the VTE prophylaxis, and how you could always think about it as someone is trying to care for the assessment, the best strategy, and what would be the best benefit and minimize the risk, and what would be the appropriate prophylaxis in hospitalized patients and after discharge. And again, we do have blood clots in the community, and for reasons we could identify with the science, with the knowledge, with the technology we have, sometimes we were not able as of today, but regardless we treat. There is the risk of coming to the hospital, and again, that is my practice, where coming to the hospital, sitting in a bed, getting medications for other medical issues would also increase that risk. And there's always that thought that we need to make sure we reduce that risk. Share with you personally, I do have always systematically add a couple of points every time to make sure when I see patients that I check off the box of yes, I address that clot medications risk, or if the patient is moving, probably does not need it because the risk is lower. So I always try to customize and apply the best practice for each patient. This is not what I would describe one size fits all. It comes down to each patient. And that's very important for all of us when we advocate for our loved one in the hospital. We need to ask the questions about what would be the best for mom or for dad or for my sister or my brother or children, and how we can always think about it and advocate for it. And most importantly, how we could put science around it. That would be probably a good transition when we talk about support group. And the support groups, and I love this definition from the thrombosisuk.org website, where it is a priority for everyone, capitalize know the risk, signs and symptoms, and support research to extend understanding into, most importantly, prevention and best management of clot or venous thromboembolic events. So if you just look at the slide and see that we need to know what is exactly that means. We need to know the symptoms. We need to advocate for everyone and make sure we understand how we prevent it. And when we get it, the prevention maybe stop, but that's where the management and the treatment starts. And there are a couple, I would say, of um, thoughts or bubbles. Let's put it in terms of bubbles, and that would be a segue for the next slide, where um, how could we get there? How could we have that engagement um, from everyone and always think about that patient in the middle? This is a nice illustration of an article I always cite there, and it's from BMJ, British Medical Journal. And as you can see, there is always the patient perception and experience, and HAT is hospital-associated thrombosis. And you will pick on the keyword. So if you start from the top, assessment of the risk. Uh, who really has the assessment and how you can make it aware of it. You are at risk. I tell my patients, you are at risk. And the answer is, what does that mean? And the answer is, there is higher risk than myself if I sit in that bed to develop VTE. But then that would be really the experience of prophylaxis. I do prescribe the stocking, the injections, many medications, but there's also that. You remember, you're not just putting that order and say this would happen. You need to make sure we also support our patients. One of the best experiences I had, and I do not know if this is a standard across the training program. The idea is, if you order something, you need to try it, and it's really not just exposing doctors or trainees to something toxic. The idea that if you prescribe it to someone, you need to really feel what it would be when it's on you. And one of my requests was, can I use these stockings that we prescribe it for our patient and we put them on our patient? And it's not a pleasant view. It's not a pleasant feeling to have something really tightening your legs. And it's not when you just walk or when you go and work out or anything that you would think it's a term of a luxury to have a stockings. It's really something squeezing your legs, preventing that mechanical aspect of having the risk of clots up. But at the same time, it's very important to try it. And that's what I call it, the patient experience. How could we feel what the patient has, and how could we make it better, and how could advocate, and how could we make that experience at least less harmful and less unpleasant. I'm not going to call it pleasant, because being in the hospital is not a pleasant experience, but how could we reduce it and make it acceptable? The knowledge of the symptoms is what you will see in every campaign that when we care about. Please know, if you get a heart disease and get a chest pain, you need to go see a doctor. That is one. But I don't know, and the number has been reported in many studies, when you see your legs, they're swelled up after traveling on the airplane for a long period of time, and the left bigger than right, or the right bigger than left. Should you just wait? Should you just elevate it? Should you seek medical attention? And usually this is very important. Yes, please see someone who could at least assess it, could get a test, could be more reassuring, but there's something there. It needs to be addressed. And there's also the experience that now it is one of my special interests is when you send someone back home or rehab or a facility after discharge. How could you engage the primary care, the doctor who usually we all see in the clinic yearly or on monthly or sometimes weekly basis, and how we could communicate what we've done in terms of the care during hospitalization, specifically for VTE. When someone gets the VTE, it is treatable, it is avoidable. I'm not going to say 100% avoidable, but it is treatable, and how we could communicate the signs and symptoms and knowledge to the patient, and also reach out to the doctor after discharge and make sure that physician, that clinician, is on the same page with us and what we saw during hospitalization. And then the last aspect that we always talk about is really that perceived gaps in patient education, is really about how we can do this public awareness and making sure that the knowledge we know it all spread, and attending many of the support groups. I know we all know something. Would it be great if we all know everything we all know, i.e. if we exchange the knowledge? I think that would probably get us closer to full knowledge. And that's the idea about getting that experience and making sure that when we see it, we treat it, and making sure that the disease that known as VTE get reduced and reduce more and more and more. And hopefully one day we'll be able to eliminate it until every PE, until every DVT is treated and hopefully prevented. That's a goal that we might reach, we might not, but that does not mean we should stop. We should keep going. The next slide is a slide from the World Thrombosis Day. Unfortunately, 1,600 deaths per day. Going to the hospital, think VTE. And that's why I personally go through the VTE prophylaxis every patient. And now this slide is also from the World Thrombosis Day, and it's from a study that was done about big portion of us, 85% of American, they know what blood clot is, but only 27%. So this is probably almost like a little bit more than 1/3, but they say they know of VTE. So we need to increase the knowledge. We need to spread it. We need to make sure we all know what would be the best for us and everyone's around us. And I like this picture, and the idea is early ambulations, or the moment you start ambulating and you start walking around, you stand up, that risk gets less and less in terms of VTE. So regardless of how much we come with in the hospital, that walking, ambulating, doing something even smaller as sitting in a chair and just raise your legs and put them down, it would reduce that risk. And this is very important. The more we move, the lower the risk of having the pulmonary embolism, PE, and DVT, the deep vein thrombosis together, they're the VTE. I always ask, please walk. Do a couple walks a day. Do a couple rounds. Don't stop there. Please don't stop. Keep going. Keep pushing yourself. It's probably easy for me to say. It probably would cause a little bit of discomfort, but I'm ready and willing to put myself there out there for my patient, to make sure that she or he will be able to walk a little bit, and hopefully that risk will be reduced. So besides coming to the hospital with the blood clot, It's also important while we do operate these 900,000 beds in the United States that everybody would be able to walk. And even though maybe not everyone is sick or um, the term is having a life-threatening hospitalizations, that we also try to make sure that when you will enough, please walk, please move, please keep going and don't stop. In the next couple minutes or so, I would like to summarize at least the this short presentation that when anybody comes to the hospital, um, um, many risks could happen. The floor in the hospital might be slippery. It is a confusing place, cold place that someone would be able to slip on the floor. And sometimes I personally uh, uh, slept on the floor. It happened to me. Um, and we give a lot of medications, and we try our best to build that uh, best ideal environment to make sure we eliminate all the adverse events during stay. But there is something specifically related to us as a human being is about moving. When we be able to move more, that risk of having clots in the legs and going up to the lungs, the DVT and PE will become less and less. Ambulate, ambulate, ambulate. And the other part that I want to share with you is usually when anyone is in the hospital, um, uh, someone is doing that risk assessment of what would be the best for the patient, and either aim to put prophylaxis, put a blood thinner, or mechanical compression to reduce the risk of having blood clot. When a blood clot forms, there's also a treatment for that. Maybe sometimes the same medications but different doses, sometimes different medications. But the most important is really keep looking at the signs even during hospitalizations, and alert the provider during hospitalization and even outside of hospitalization, and make sure you also engage in the treatment plan. I always tell everyone, probably the most non-adherent human beings are physicians, uh, but I recently learned from also my wife was a lawyer that the lawyers that also argue in court and outside court. So the whole idea is really how could you engage it. This is not about the argument. It's about spreading the knowledge and making sure that everyone is receiving the right treatment for the right cause and reducing something. And I would like to make sure we're all on the same page. It is avoidable. Avoidable by medication, avoidable by walking, ambulating, and making sure that this will not happen to anyone around us. The last part I want to tell you about is if anyone is in the hospital, or your loved one is in the hospital, engage the hospitalist. It's a new field. It's you probably encounter one of these hospitalists, and now I'm hearing more and more about oncology hospitalists, about cardiology hospitalists, about neurology hospitalists. So the field is more branching and decent. Again, the providers who in the hospital and they do not have a clinic, just the conventional terminology, engage them, bring them to the room, say why and how and did you think about it. We do have systems in place. We do have quality dashboards. We do have uh, a management for the whole service on the patient level as well. But I think with spreading the knowledge that we talked about and what would be the best to support everyone around us, that we all advocating for a good cause, the best treatment, the best care, and prevent the avoidable VTE. With this, I would like to open the floor for any questions. And please feel free to ask any questions about hospitalizations, about hospital medicine, about VTE, about prevention, treatment. And if you have any also reflection or a reaction to share about what would be the best also for the medical community, for the patient support groups, would love to hear your thoughts, would love to hear your comments, and I hope we all be in it together to move it forward. Thank you very much. Molly?
Well, thank you so much, Dr. Barkoudah. We did get a few great questions. So let's get started. One patient says that she was hospitalized a few times for diverticulitis, and each time that they tried to insert an IV, they had trouble and it took them many attempts. And she wants to know if it's possible for an IV to form a PE or for it to be related in any way to that.
Correct. So um, there are a couple of lines. There are the venous access, call it the butterfly. They said the small needles that they go in the superficial veins, but they would have access to the actual venous system for any administration of medications. Um, Usually these are smaller, and each vein has I would call them small valves. So even when they get the thrombosis, they're still superficial. So I would like to share with you a couple of specific nuance that superficial is different than deep. And the D in DVT is deep vein thrombosis. So that clot should come all the way down to the main vein to cause DVT or to cause uh, a clot that would float all the way and goes to the heart and then goes to the lungs. Usually, in the way I understood the question, it is likely to be maybe an irritation in the veins. It could be related, it could not be related. So there are cases that when we uh, try to put an IV, there will be an irritation, but that does not mean DVT. But there's something else I usually share it with everyone. Um, we always focus on the local organ where the needle went through, uh, but we're also coming to the hospital for a reason. So it could be more how sick the body is rather than sometimes the needle. It's hard to ascertain specifics, but again, usually the fluids and the antibiotics, they go through the vein. They usually go into superficial veins, not deep veins. There are lines for the deep veins, but usually these are for long-term medication administrations that when we send someone out of the hospital to receive antibiotics for a couple of months, there will be a longer vein access, more deep. The technology in these deep vein accesses, it really came a long way, and it's very hard to form a clot. At least my clinical practice and my practice, because I only see the hospitalized patients who need care. I really don't see any, or maybe few. We think it's probably not the access, uh, uh, not something that been caused, is probably how the illness systematically is affecting the body. I hope that that was helpful.
That was great, Dr. Barkoudah. And that same person wanted to know, is there anything else that can cause a PE other than a DVT, or does a PE always start as a DVT?
Excellent question. The answer is not. There's not always. There are primary uh, pulmonary embolism, so the clot goes to the lungs without really finding evidence on ultrasound in the legs. The one hypothesis that it was in the leg, but then it moved up to the lungs and caused PE. It's hard to know, but the standard of clinical practice is to make sure the primary diagnosis of pulmonary embolism to obtain an ultrasound on the legs to make sure there is no DVT. That would not change management. And there are a couple of advocates that they say this would add more to the diagnostics and the patient, I would say, going through more testings without really changing the management, because the management will be putting or starting the anticoagulation of the blood thinners. So there is no need to do it. There are a few cases when, if there is a specific source in the legs that keep having the clots and it keep sending the clots up, it needs to be mechanically sometimes addressed. That is not the case at large. It's probably less than 10% of the patients. But again, systematically, and if you see any of these articles, systematically we think about it. So to summarize, not always we will find the DVT, maybe because it's already went up. Sometimes we find DVT with PEs. And if the process is more chronic, if someone been in bed for quite some time, bed bound, or after prolonged surgeries, or after motor vehicle accidents, there will be evidence there. So the clot would leave evidence that we know there's DVT there, and then it goes up to the PE region. The last thing I would like also for the support group here to share, that regardless of how we see it or where we see it, we treat it. And sometimes, if it's small in size, the treatment is the same. I would say most of the time. So the question I always get asked is, do you do more ultrasounds? And the answer is, if it's not going to change my treatment plan, I'll be more than happy to do it, but it would be more discomfort for the patient rather than having a meaningful answer, i.e., even if we find it, we need to keep treating. This is one. I practice at Brigham and Women's Hospital in Boston. I'm on the faculty at Harvard Medical School, and I do courses also for the medical school. We are cautious of what would be the best risk benefit. And I remember the day when someone said, well, you're trying to save money for the hospital, or you're trying to save money. And the answer is, there's no cost reduction. There's just the share of idea that if I ask you to come to get an ultrasound just because I would like to get another one, there's a risk even coming to the hospital, catching flu, especially the season of January through March, which I live in right now, where everybody's coughing. If it doesn't change the management, I always think about it. Do I need to bring my mom or my dad to the hospital for something that it's not going to change really what I'm doing? If the answer is no, the answer is no. The last point I would like to point out, it's very important also to know when we get blood clot that we have a little bit of documentation physically at hand, or now on our cell phone. I ask every patient to write it down. I had a blood clot in my vein in my left leg in April 2014. Write it down. Make sure you know it, and everybody around you know it, in case it comes back, in case there's something else that could be addressed in the future. Excellent question.
That was great, Dr. Barkoudah, and we do have a few more. One patient writes, she was recently diagnosed with a PE, and she wants to know, is it recommended that with a new PE diagnosis that you be seen by a hematologist? She has not, and has only been to the thrombosis clinic. She also says that she did not ever have an ultrasound of her legs.
Okay. So I am so sorry for your recent diagnosis. It is treatable, most of all, and I hope that clot would dissolve. Um, the hematologist question, it really depends. Um, Again, I practice in a medical center, as I shared with you, where we are also very diligent, the hematologist, and the hematologist really does not take all the consults. If there is no question, there is no consult. Um, we tend to address the hematology consult outside the thrombosis clinic in specific questions. And the questions is this is a case that runs in the family? Do I need to do specific genetic testing? Do I need to do specific blood clotting factors? And this is very small portion of the patient, and it's I am confident that the thrombosis clinic thought through this. It is a disease that's shared with many disciplines. So it'll be cardiologists, cardiovascular medicine, the vascular component of it. We do have anticoagulation clinic, could be a pharmacist, a hospital medicine could be involved, primary care could be involved, hematologist could be involved as well. But this is very small portion. It's really based on the history provided and how the your physician saw the details of the case. It can go either way. Um, I think the communication it is important. Where if you share that with your physician, say, well, there is probably a something similar in the family, or um, I I have something called this blood factor or clotting factors that need to be addressed. Um, there is something about medicine that we all know about for this group because of the exposure to healthcare. Uh, the medicine is really based on the relationship with your providers, and how you frame it, and how the provider is looking at it, examining the data point, and making sure you're getting systematically diagnostic and treatment approaches. Again, it's not one size fits all. Um, the best practice is to make sure you're seeing the person to address specific questions. With the ultrasound, we do ultrasound. And, again, there is a bigger group. They're saying this is an additional cost with no added benefit. If there is a PE, you could just treat it. It really depends on also the symptoms. If there is no asymmetry in the leg, there's no pain, nothing really there, there's no recent trauma, we now know that PE could come without DVT. Um, to summarize about the multidisciplinary care, there are many centers where they bring a couple subspecialists and they lump them together for one consult. Sometimes, or most of the times, it's not. A provider refers, the primary care refers the VTE patient to the thrombosis clinic or the anticoagulation clinic or the vascular medicine clinic. Um, the art of communicating signs of symptoms and what would be a higher pretest probability in terms of working out what would the hematologist would be providing. Uh, my last point is the following. If you are on treatment and hematologist is seeing you, is not going to change treatment. So this is more a diagnosis, the art of diagnosis rather than treatment. I hope that that's helpful, and I'm so sorry for your recent event.
Thank you,
Molly?
Dr. Barkoudah. And then that same patient had another question and wanted to know if you could explain the difference between provoked versus unprovoked pulmonary embolism.
Excellent. Um, we the way it works that provoked, I'm going to put it in much bigger discussion. It's where something caused, for example, trauma, or someone had a fall fracture, and that damaged the actual blood vessels, and that caused what is a provoked event. Unprovoked, it happened on the cellular level without really knowing an extrinsic factor. So more intrinsic factor. So nothing really we think it caused. The definition is a spectrum. So what we most of the time, even in our practice, we could call it likely to be provoked. When on a plane, 12 hours flight to China. On the way there, felt something, stood up, the leg got bigger, maybe provoked. Would that mean it happened before and it was unprovoked, but then on the plane, the specific position made the blood flow a little bit asymmetric? It could be. It, this is the first part of it. Could be kind of in the middle. It could be tilted to one of the other. I like to classify them where we say this is provoked or unprovoked. The treatment is the same. So if it's provoked and unprovoked, it would be an anticoagulation, an oral or injectable, which also important that it doesn't change the treatment. In academic medicine, we like to have more details. We do want more clarity in the data, more granular level data points. So we always try to piece it together and piece the history and the diagnostic testing to get it provoked and provoked. So the way I see it, if it's a result of extrinsic factors, it's likely provoked. If it's not, it came spontaneously, it is unprovoked. Again, the treatment is the same.
Thank you, Dr. Barkoudah. And then we have another question from a patient who was recently diagnosed also with a PE in November, and she is currently thinking about potentially going through some form of treatment for something else. She says that she has a left L5-S1 nerve compression, and her orthopedic doctor has suggested a minimally invasive injection or a procedure called a discectomy of maximum fusion. And she wants to know how significant is the risk for an injection, and when would she maybe be able to suspend her anticoagulation for an injection?
Excellent. This is an excellent question. First of all, I'm sorry for what you're going through. Seems like there is a surgery coming up, and you just had the PE. We do have clear guidelines regarding stopping the anticoagulation before doing surgery. Your surgery, pleased to say, it would be shorter in terms of the healing. So anytime we are on blood thinners for the group, and we even stick a small needle, there's a high tendency of bleeding. Imagine that you're going near the spine. You need to be very diligent. You need to be calculating that risk benefit and making sure there will be no blood formation around the spine. There are guidelines, and we do stick with the guidelines, and there are two practices usually. Most of the spine orthopedic surgeons, they do work with a medical doctor to do the medical evaluation, where I would encourage you to discuss that with your orthopedic physician or your spine surgeon. Say, I am on a blood thinner. I would like to have an opinion about stopping and restarting. The restarting is usually up to the surgeon, and it's usually in the realm of the second day to the third day post operation. Stopping the anticoagulation depends on the type. There are the injectable ones. If you take them twice a day, it means it would last 12 to 24 hours. So we stop them sometimes 2-3 days, sometimes 5 days. So we try to stop them a little bit also before, to make sure when we do the operation, there will be good healing, there will be good clotting, and it will not really affect very sensitive regions like the spine. The warfarin sold commercially under Coumadin, it takes a little bit longer to clear up from the system, sometimes 7 days. We do a couple of testings to make sure the INR, that's the test that we check the bioavailability of the clotting effect, came in down near 1 instead of being in the range of 2 to 3. The other direct anticoagulations, we do have 4 in the market, and they really varies. Most surgeons, they like to see it at least 3 to 5 days, and I thought that is fair. Let me just share with you this as well. There's always a risk in theory that stopping anticoagulation, even for a short period of time, could have a risk to have a blood clot during the period when you're off the blood thinners. Let me just put it in context. So we all do have a risk of 1%. Let's just put that number, but that 1% is accumulated over a year. So sometimes the risk of being off for a couple days, if it needs to happen, and there medical providers involved in the care, and that is the recommendation, that's the risk benefit that we would like to accept for what would be the best for your care, I think it's reasonable to stop. And then when you restart, the risk would go back to the treatment risk, which is much lower than not having the medications. Please discuss with your spine surgeon about the details. Again, many folks, they refer to a medical doctor who she or he would do the pre-operation evaluation and would give you specific recommendations, or at least I'm going to call it instructions, not even recommendations. Stop this, start that, make sure you don't eat this or don't eat that before the operation. This medication needs to stop. If you're on aspirin, it needs to stop for 7 days. Anticoagulation sometimes is 5 to 3 days prior to the operation, and then it gets restarted when it's safe after the operation. This is one. Number two, there is something very important, and this is an interest of mine as well. Write down your medications, write down the instructions. Now most of these softwares for management of clinic, hospitals, they print out specific instructions. Follow them. This is very important because if you remember that the scale I put, keep tilting, risk versus benefit, make sure you are in the middle, you're balanced, you keel. You're not exposing yourself to a risk. The other part that I always tell at least my closer friends and family, advocate for yourself. If you're going through surgery, discuss it with your doctor. Say, I do have clot, and I would like to make sure this has been addressed, and you are aware, and I would like to discuss a plan of how it would be restarted. I wish you the best in your surgery, and I hope it would be the minimally invasive, not the discectomy. It will be hopefully faster healing. Best of wishes, and I hope everything goes well, and I'm sure it will. And I hope you get back on your anticoagulation after that. During hospitalizations, they do have a couple protocols. It could be sometimes a prophylaxis protocol. It could be encouraged ambulation, as you saw, or both. This is very important. All hospitals I'm aware of, they do have that on their radar, and it's part of their quality assurance program to prevent any other events during hospitalizations. Wish you the best.
Thank you so much, Dr. Barkoudah. And we do have one last question for tonight.
Okay.
This patient wants to know, when they go into the hospital, if they do ever have to be in the hospital for overnight or for a long period of time, what kind of questions should they be asking their doctor to help determine if they are at risk for a blood clot?
Perfect. Um, Excellent questions to be on the list for tonight. Um, Here are my recommendations, and I don't have the magic bullet. I am like everyone else in the trenches, doing my best day in day out. Couple of things they're very important about being in a hospital is to minimize your risk. So I'm going to zoom in on VTE. Otherwise, I will keep the group for a couple hours listening to my recommendations about the hospital. Um, Rule of thumbs: if patients is walking around uh, in the gown and the Johnny in the hospital more than 4 times a day, it's probably adding a anticoagulation for prophylaxis. It's maybe could be avoided if the patient is walking. So if you're able to walk safely in the hospital, do a couple laps. We here at the Brigham, we ask the patient to do laps because we do have a big circle around the pods on each floor, so they do not need to leave the floor. Um, if they do a couple a day, there will be no need for prophylaxis. This is one. Number two, if you're getting something, please know what you're getting and how you're getting it. And sometimes you could be off the floor for a CAT scan or imaging or some diagnostic testing, and you did not get your dose of the VTE prophylaxis, if it's injectable or not. Ask your nurse, engage your nurse. Every hospital now, by the ACA law, um, it's mandated to have some electronic records, but these are machines and we're human beings. Advocate for yourself. Say, well, I did not get my VTE prophylaxis dose. Um, um, if the best answer is, well, you walked 5 times and I discussed it with your hospital medicine clinician or physician, and she or he said you're doing well, you do not need it, that would be the excellent thing. But you also remember that you do not want to miss it. And you need to advocate for yourself because these are alerts in the computer. So advocate for yourself. Discuss it with your physicians. When you come to the hospital, um, the best time is when the physicians or the clinicians they round, and we do teaching rounds here at the Brigham. It starts every day at 8:30. Everybody sees every patient all together. We discuss it. We address the patient's questions, and we always discuss the medical plan, and then we pause. And my favorite patients, and I hope you're one of them, the one they pull a pad or a notepad or a piece of paper and say, I have questions for you. You did not give me VTE prophylaxis. Why? Well, I saw you walking 3 times, Mrs. T, and I think you're walking more than me if we compare notes on the iPhone or any other software. That is the best answer. Advocate for yourself. The other part is the idea of hospital associated adverse events. Hospital associated thrombosis is real. If for some reason this happened in a hospital, if the prophylaxis was not effective, and you saw um, signs of a VTE, uh, discuss it with your doctor. Sometimes things happen. We cannot explain everything in the human body, and we want to make sure you're also aware that you tell us, hey, my leg is much bigger than the left, bigger than the right, or I'm feeling really shortness of breath and I don't really know why. So this is also the communication. In summary, keep the communication channels open, keep the dialogue with your treating clinicians when you're in a hospital. Take notes, ask questions. It's allowed. It's your right. It's your right. And the patient's right is a document that should be in every place where this is your stay, and we're there to help you. We're here to serve you. Ask questions, engage your clinicians. If you are on anticoagulation or not, in prophylaxis and treatment, ask why. Uh, the patient who are engaged, the patients who are asking questions, usually uh, uh, getting the treatment that is more and more accustomed to what they have and what would be the best for them. I hope you would come for the hospital for a cup of coffee and not for acute illness. So with this, we're 8:01 uh, Boston, New York time, Eastern Standard Time. Uh, I would like to thank you for allowing me to be part of your evening for an hour and share with you a couple of tips, couple of recommendations that I hope it was uh, uh, helpful, provided a little bit of context. Uh, if you do have a VT and getting treated, this is the right. And I hope you continue with this dialogue with your treating clinicians. And I hope no one else going forward would get something avoidable like VTE. Thank you very much. I'm grateful that you allowed me to share with you my thoughts for the past hour. Thank you, Molly.
Thank you so much, Dr. Barkoudah. Um, I did want to share with everyone that our next online support group will be on February 4th. We will be joined by Dr. Suresh Vedantam, and he will be discussing new updates in post-thrombotic syndrome. Thank you everyone so much for calling in tonight, and have a wonderful evening.
Thank you. Take care.